A 40-year-old male patient presents with left hip pain. I'm showing you the anteroposterior pelvic radiograph. Describe the findings.
Okay, the pelvic radiograph demonstrates right femoral head resurfacing arthroplasty, indicating severe prior joint disease. The left hip joint shows marked arthropathy characterized by uniform loss of joint space, subchondral sclerosis, and subchondral cystic changes. Importantly, the sacroiliac joints demonstrate bilateral, symmetric fusion and sclerosis. There is prominent calcification and ossification along the interspinous and supraspinous ligaments, along with ossification of the pubic symphysis. Additionally, there is reactive bone formation or whiskering at the bilateral ischial tuberosities, representing enthesopathy. The findings are diagnostic of ankylosing spondylitis.
What is the differential diagnosis for sacroiliitis on plain film, and how do you differentiate unilateral from bilateral involvement?
Okay, the differential diagnosis for sacroiliitis includes ankylosing spondylitis, inflammatory bowel disease, arthropathy, psoriatic arthritis, reactive arthritis, and infection. Sacroiliitis is classified based on symmetry. Unilateral involvement typically indicates septic arthritis, tuberculosis, or unilateral osteoarthritis. Bilateral but asymmetrical involvement points towards reactive arthritis, formerly Reiter's syndrome, or psoriatic arthropathy. Bilateral, highly symmetrical sacroiliitis is classic for ankylosing spondylitis and enteropathic arthropathy associated with inflammatory bowel disease.
I am showing you 3 comparison images: a lateral lumbar spine radiograph, an asymmetric lumbar radiograph, and a pelvic radiograph showing colon wall changes. Describe their findings.
The lateral lumbar spine radiograph shows lucent erosions at the anterosuperior margins of the lumbar vertebrae, representing early Romanus lesions in ankylosing spondylitis. The second radiograph demonstrates asymmetric bilateral sacroiliitis, worse on the left side, showing subchondral sclerosis and erosions typical of reactive arthritis. The third pelvic radiograph shows bilateral sacroiliitis accompanied by a thickened edematous sigmoid colon wall, diagnostic of enteropathic arthropathy and ulcerative colitis. These examples illustrate how spinal and extraspinal findings help differentiate the causes of sacroiliac joint inflammation.
Describe the pathogenesis, genetics, and clinical manifestations of ankylosing spondylitis.
Ankylosing spondylitis is an autoimmune, seronegative chronic inflammatory arthropathy that primarily affects young males under the age of 40. It has a strong genetic association, with over 90% of affected individuals carrying the HLA-B27 antigen. The disease initiates with enthesitis, leading to chronic inflammation, erosion, and progressive syndesmophyte ossification of the outer annulus fibrosus. This syndesmophyte formation leads to the classic calcified bamboo spine appearance, causing severe spinal rigidity and stiffness.
What are the extra-articular manifestations, severe complications, and how would you manage this patient as a radiologist?
In that case, common extra-articular manifestations include acute anterior uveitis, apical lung fibrosis, aortic valve insufficiency, and inflammatory bowel disease. Severe complications include spinal fractures, particularly in the cervical spine, which can lead to spinal cord compression and death. As a radiologist, I would recommend a dedicated MRI of the sacroiliac joints to check for active bone marrow edema if early disease is suspected. I would also recommend referring the patient to rheumatology for disease-modifying therapies and advise routine chest radiographs to screen for apical fibrosis.